want to introduce the panelists. Jan Arends, great expert in clinical nutrition based in Fribourg, University of Fribourg in the Department of Internal Medicine. He's the first author of ESPEN guidelines, so we are very honored to have you with us, just to share your knowledge with us. And Andreas Brandl, who's, in spite of his German surname, he's based in Portugal. He's a surgical oncologist, works in the Champalimaud Foundation, and he's the chair of the S. Young Surgeons Alumni Club. So welcome to you, Andreas. The ASAC, that's the acronyms of the S. Young Alumni Surgeons Alumni Club, has held some surveys about nutrition in the last years. So we will illustrate us some snapshots from real life concerning this kind of argument. So if you agree, Jan, I will give the floor to you. So you will introduce as the topic of our webinar. Thank you.
Yes, Sergio, thank you very much. So I'm a hemato-oncologist from Freiburg, Germany, and I will talk a little bit about nutrition, and you had some questions for me, which I'm trying to answer as good as a non-surgeon can try to do this.
But the interesting thing, from my point of view, that we are facing an argument that is not that familiar to surgeons. So,
yes, so
that you are not a surgeon, that's important too, in my opinion. You're not biased by your culture and your daily practice. So
it's always good to communicate across the different areas. You're completely right. Can you see the slide? Yeah, okay, great, good. So cancer cachexia in surgical patients, and to be honest, from my side, of course, I'm seldom asked how do surgical patients do, but then again, those are always the same patients across the different treatment areas, and I will try to show what this is from our side. So here are my I'd say potential conflicts of interest. Of course, nutrition is on the list. And let me briefly start. These are quite recent data on the incidence of malnutrition in a mixed population of cancer patients. Now, these are medical oncology and radio oncology units taking the incidence at two different time points, 2012 and 2014, and no surgical unit, as I understand, in this Australian paper. However, looking at the different entities, you can see that malnutrition varies between 50% in upper GI cancer to like 15% in gynecological breast cancer, but on average around 30%, every third patient is malnourished. And I think these are the same patients that should go to surgical interventions. So it is very frequent. And when we're trying to find out a little bit what might be the background, the causes, obviously it is not an increased energy expenditure leading to weight loss and malnutrition. On the left side, these are data almost 15 years old, showing that resting energy expenditure in cancer patients is a little bit higher compared to healthy controls. However, at the same time, these patients are less physically active and have less expenditure for moving around. So the total daily energy expenditure, usually, that's what we write in the guidelines also, may be taken to be similar to healthy controls. So it's not an increased or higher energy expenditure. However, cancer patients have much lower food intake, and these are data from Lisbon, Paula Ravasco, already older data, but it's still this situation. And she was looking at different GI cancer patients, early stages versus advanced stages, and looking at the amount of calories taken in compared to healthy controls. And You can see in early stages, maybe a little bit less, but in advanced stages, almost 500 to 1,000 kilocalories per day, less energy and food intake. So this is the major reason for being malnourished and losing weight. And at the same time, it has been shown that cancer patients, especially in an advanced stage, have much less physical activity, and you might measure it with accelerometry and comparing the number of steps taken per day compared to healthy controls, left side or the middle early stages of cancer and advanced. Much less steps per day and much more time spent sitting or lying and less time spent walking around. So that's also a negative factor for muscle mass, because we don't have this anabolic drive by physical activity. And the fourth picture here is, so this is a surgical group. This is a surgical group from Donald Macmillan in Glasgow. He just tried to make sense out of the situation that most cancer patients, the more advanced they are, have an activated systemic inflammation. And he was just looking at CRP, either normal or raised, and albumin, either normal values or below the threshold. And he was just making it a three-step score, giving the best score of 0 to all patients with normal C-reactive protein, giving a score of 1 to those patients with raised CRP but normal albumin, and the worst score 2 for those patients with chronically activated inflammation with increased CRP and decreased serum albumin. And this is a group of successive cancer patients in our unit, and you can see that most of these patients have a raised CRP, though they're receiving chemotherapy and being treated, and are basically, well, not dying. And many also have a bad score with decreased serum albumin below the threshold. Not all have very low levels, some do, of albumin, but at least this is an important sign of systemic inflammation. And I will show you in a minute outcome data for these scores. But just taking together the last slide and making some simple graph, our patients' body weight and especially tissue or muscle mass are influenced by food intake, which often is inadequate, as I've shown you, by physical activity, which is driving muscle. If we are not physically active, we lose this anabolic drive, and by surplus systemic inflammation, which is decreasing muscle mass and, of course, feeding this into immunological organs. So we have proteolysis and protein breakdown, as you know, in surgical patients. And taking the at present gold standard of measuring muscle mass, looking at CT scans and just painting Hounsfield units for muscle tissue in one color, you can see patients with the same body mass index, the same body weight, may have completely different amounts of muscle mass. These are always taken at the standard level of lumbar 3, and these the areas are very predictive of total body skeletal muscle mass. So if you just take the body weight, you will not be able to tell this. You need to have some technique of looking at body composition, but then you can see patients with very low muscle mass, very little red area, and this would be termed sarcopenia. And this has been followed for many years by now. This is a systematic review published 5 years ago in the European Journal of Cancer, looking at more than 38 trials, which all looked at cancer patients and comparing low muscle mass, sarcopenia, with clinical outcome. And there was very high correlation between sarcopenia and poor overall survival, or poor cancer-specific or even disease-free survival. So this is very robust, this correlation. Muscle mass should be one of the parameters when we're looking at our patients. And systemic inflammation similarly is extremely important. And this is just one trial published 2014. Colorectal cancer patients followed up over several years, initial treatment at time 0, and just looking at the survival curves in those patients with a best score of Glasgow score by Donald Macmillan, 0 points, 1 point, and 2 points. And you see there's a highly significant stepwise decrease in overall survival when taking this score at the time of primary treatment. So this is, it's very robust, and looking at 2017 systematic review, and by now there are even more trials, just colorectal cancer patients. You can look at different other entities, and systemic inflammation as measured by this score is correlated with an increased hazard ratio of death. So this is, I mean, we can just take this for granted now. Sergio, you then asked me some question. What should I talk? What is the definition of cachexia? I have not said this so far. And are cachexia and malnutrition, these terms, somehow related? And just, I mean, we can make it very complicated, because during the last 20 years we have had different definitions, and if you change the definition, you have a different fraction of your patients being malnourished or sarcopenic. I'm showing here one, which paper published by geriatric group, and they're having these terms: sarcopenia with this green color, frailty blue, cachexia red, malnutrition yellow. Well, I put in the colors, but just separating this for their group of patients. And if you just look at red cachexia and yellow malnutrition, there is the impression you have more cachexia than malnutrition. And this is not what we, this was published 2019, but this is based on the definitions used, and in fact they use the definition for cachexia, the red rectangle here, published by Evans in 2008, and the definition is given up here: weight loss and 3 of the following 5 parameters of decreased body composition, let's say fatigue, anorexia, raised CRP. So this is not the up-to-date definition. They use this one, and for malnutrition they use the definition published by Espen in 2015. And again, this is not the definition we are using, or we should be using today. I'm just showing you what can be done, and again, this was published 2 years ago. So this definition says you need a screening test for malnutrition, and you need a very low BMI, body weight very low, or weight loss and a little bit higher BMI, but still much higher than most patients in most of the European countries by now. So that's what may come out. I'm just showing you, depending on the definition, the answer will be different. And if we look at the consensus group recommendation published by Ken Fearon, the late Ken Fearon, again, another surgical group, published 2011, and they said cachexia in the end is body weight loss, maybe not so much, 5% of normal standard weight, plus some form of systemic inflammation, maybe anorexia, maybe decreased food intake, or measuring inflammation. So weight loss plus inflammation. And in fact, because there was, I can just show these few definitions, there have been many more, and there has been, we were all disappointed because it's difficult to communicate if everybody is using a different definition. So there was this global initiative, GLIM, Global Leadership Initiative for Malnutrition, by the major European, North American, Asian and South American nutrition societies. And this has been published in the ESPEN journal and the ASPEN journal, and my and many other propositions are to use this just to have the same language when talking about malnutrition and cachexia. And the idea is to define malnutrition by 3 different criteria. You need a screening tool for malnutrition. So there must be some indication there is a problem with the patient. You need one phenotypic criterion, and you need one etiologic criterion. I will just show you. Looks complicated, but in the end it is not. You need one pathological screening test. I will show you some just to have an idea how they look. You need one criterion for the phenotype of the malnutrition. This may be either weight loss, 5%, again, like on the last slide, or a low BMI, not both, one is enough, or a low muscle mass measured by CT or whatever is a validated tool. And in the end, this is more research. Very few will do this frequently. You need one of these, usually weight loss, and you need one criterion, either low food intake for at least 1 week, or chronic malabsorption of a relevant degree, or you have systemic inflammation. And then we would call it cachexia. So you have weight loss plus systemic inflammation. And in the end, this is the same as the Ken-Fearon group published in 2011. And that should be the standard of defining malnutrition as the big term, and cachexia is a component of malnutrition. So cachexia is one subdivision of malnutrition. And I've shown this before, just to say it again, most patients have a raised CRP, they have systemic inflammation, but maybe not so much. CRP does not need to be extremely high. This is in milligrams per deciliter. Today we are measuring this in milligram per liter, so you need to multiply this by 10. But if it's above, even a little bit above the normal threshold, then we would call it inflammation, and it would be cachexia if the patient has lost weight. So you get the definition, the diagnosis of cachexia, but you need not be in a very, very severe situation. You need not have lost 30 kilograms of body weight, but it may be enough you have lost 5%, which still is a little bit. I'm just saying cachexia may be a very mild form of inflammatory malnutrition. And if I'm just showing this by an idealized graph, we have malnutrition, several different forms. We have malnutrition in third world countries, not enough food available. And we have cachexia, which is disease-associated, inflammatory malnutrition. And most, or maybe all patients with cachexia have lost muscle mass and tissue mass, but sarcopenia may also be present in elderly and frail patients without a tumor or some other form of active disease. So sarcopenia is maybe just a standalone situation. Okay, so that's how we're trying to do this, and paper and articles are accumulating now using this definition, and we of course hope that communication among different groups will improve by using this definition. So I've just from giving this, the answers should be somehow, well, possible, even though in the individual case it may be difficult. Is cachexia a contraindication for elective surgery? I would say cachexia is this: you get the diagnosis, but the severity may differ, and you will have patients who have a non-tumor associated inflammation, and of course you would treat the pneumonia or some other infection, and you will have a normal patient again. If it's tumor associated, you might have a curative option, and if you remove the tumor and the patient is cured, then inflammation will be gone. And in the palliative setting, you may have patients with a very nice survival of a couple of months or even a year, and others with a very poor prognosis. And of course, these patients would be very close to exclusion criteria, or but it's standard assessment as you're doing, I guess, in surgical, pre-surgical care. Why do we have to screen for malnutrition, and how can it be done? Even in surgical patients, well, like in all other patients. This is the ESMO practice guideline, published this May in ESMO Open. It's open access. You can download it from the ESMO page. And we say malnutrition risk screening should be done in all cancer patients, beginning with diagnosis and repeated as frequently to not miss a severe change in general status of the patient. And we are suggesting several tools. There is not one tool you need to use, and different groups are very happy with different tools. I will just briefly show you some of these just to get an idea. And if you're interested, of course, you can read this. But the main message is it's more important to do the screening than to use a specific tool. One is the MST, Malnutrition Screening Tool. It's from Australia, and they are asking for weight loss without trying, and have you been eating poorly because of decreased appetite? So it's just these two questions, then depending on the amount of kilograms or body pounds. Usually, if there is something not normal, you get a risk result. There is this from the British Nutrition Society, from BAPEN, MUST score, malnutrition universal screening tool, and they are asking for body mass index, weight loss within the last 6 months, and whether there is some acute disease effect like raised temperature or fatigue or whatever. And you are adding points, and usually if something is not normal, you get a risk score, and the patient should be followed or even visited by a nutrition specialist. And Esben is proposing this since 2000, so 20 years, nutrition risk screening, and it looks a little bit more complicated. We've implemented in a digital tool. We are just handing over to the patient. They say whether they eat enough, whether they have lost weight, and so on. And the tool just spits out the points. And it's composed of 1, 2, or 3 points for nutritional status, either normal or impaired by more or less. And you might get 3 more points by the severity of the disease, and mild scores, moderate and severe scores. We have some oncology patients get 1 point, hematologic malignancy, bone marrow transplantation, but major abdominal surgery or intensive care patients, they also get 2 or 3 points. And elderly, more than 70 years, get another point. And so it's just adding points. But so this, you don't need an expert to get these scores. And these scores are mainly done to tell you which patients require more attention and care, either by a nutritionist or by a nutrition physician expert. I think that's what Esben is heading for. But again, basically, you need time reserved for these patients. And there's a snack score from the United States where they're mainly asking for appetite, or whether patients are feeling full and food tastes good or bad. And normally I eat so many meals per day. And they've shown this is very sensitive to predict different degrees of weight loss. Just don't remember all of these. So there are a number of tools. You need to choose one and should establish it and not burden yourself, but have somebody do it, maybe the patient, and get a digital readout. How can we treat cachexia? Well, if we screen for it and we know it's relevant, there should be some treatment. And basically, it's supplying energy and nutrients. Of course, treating all, what we say, nutrition impact symptoms, everything that's causing the patient to be unable to eat or not being happy with eating. We need to decrease catabolic drivers, treating wounds, treating infections, maybe symptomatic decrease of inflammation by non-steroidal agents or omega-3 fatty acids, not extremely effective. There are some anti-cytokines in trials, ongoing trials. And we need to add anabolic agents, which is mainly training the muscle and providing adequate amounts of energy plus protein. And when you're the surgeons, you're treating cancer much more efficiently, much more quickly than anybody else can. And if we remove the cancer or debulk the cancer, then this also will improve malnutrition and cachexia, because we don't have this inflammation burden anymore. So that's an extremely important part. And cachexia doesn't mean these patients need to be left by themselves and treated by palliative care, but if possible, treating the cancer will be an important component of improving cachexia. recently published this more colorful ESPEN guideline on surgical, on nutrition in surgical patients. And I'm showing this, so it looks complicated and you can really get lost in this, but of course it's elective surgical patients, preoperative surgical patients, they should be screened. So that's what ESPEN recommends. And those patients with a high risk, which may be low albumin levels, or a high nutrition risk screening, as I've shown you before, 4 or 5 points. These patients might even be postponed to postpone the surgical interventions a couple of days and maybe to consider prehabilitation. So screen all patients if there is a risk. Maybe consider if it's elective surgery and surgery is planned for within 2 or 3 or 4 weeks, you have some time to try to improve the patient. And this guideline, this surgical guideline starts point 1 or paragraph 1 is principles of metabolic and nutritional care. And this circles around prehabilitation. And of course, we know this is not really established yet, but it's an important new goal of improving nutritional and metabolic status pre-surgery, and then have the patient with surgery, you have this dip within body resources to really decrease this and then have a much faster recovery after surgery. So that's the guideline, downloadable from ESMO site, and that's my email for any questions. So I would stop here. Thank you for listening, and I think I stop my screen share.
Okay, thank you, Jan. I can start with 1 or 2 short questions, if I can, Jan,
Sure.
just to warm a little our webinar. Andreas, if you have questions as well. My first question is you showed us different screening tools, but as far as I know, there is no huge difference between the different tools in terms of effectiveness, and so the message is choose one tool, the simpler,
Yeah, I agree.
less messy one.
Sure, exactly. And of course, screening is, the goal is to select patients. And if you have just one dietitian or one nutritionist and you have 2,000 patients, you need to you have to define which patients should be seen based on the screening. Either you try to take care of those not in such a bad situation, so you maybe are able to improve, or you select those with a high screening score. So that's not really established yet. And of course, to include more patients might be better, but I know that our resources, our dietitians, we have a limited number, and we have to adapt the score level when we say where this patient will be seen. So that's another point. Select any tool, but if you say...
So the other question is, as far as you have selected your patient via these tools, the solution is it complex or not? I mean, do you think that oral supplements and dietary counseling is sufficient per se, or you need something more?
Well, I would, yeah, you're right. I think nutritional counseling, I know that where maybe pre-surgery, say it's eating is work, just do it. But in the longer term, for our medical oncology patients, they usually may have problems also with the taste and feel satiety after supplements. So I would always combine it. Have very good nutritional counseling, say several small meals, try to increase fat, like adding cream or maybe oils or something, to get more energy in a small volume and offer more protein, and of course offer nutritional supplements. But do it together and add physical exercise. I would always say this really belongs.
What do you mean by physical exercise?
Yeah, just moving the patient, not going to the Olympics, but yeah, having physical activity.
10 minutes walk for a day.
What do you say?
10 minutes walk.
Yeah, what we say best would be 3 or 4 times 30 minutes per week. And of course, just adapted to the level these patients are able to do. So not overstrain them, that's bad, but keep them moving and not say, well, you have a cancer and you need to relax. That's probably not the best way.
I'm reading a question coming from one of our attendants. Is there any role of human albumin in postoperative state? I mean, you cited albumin. Albumin is a very controversial indicator of malnutrition. Can you clarify this point for us?
Yeah, so I think this has been going on through the last 20 years too. And finally, I think the major position is that albumin is an inflammation marker, a marker of the severity of the disease, but not of malnutrition. And by providing albumin, you're probably not doing any benefit. I think in liver transplantation, in some patients, there are some data that they may benefit from adding albumin, but generally it's just very expensive and not truly helpful. So it's not treating the cause, but a sign.
Because it's just an indicator, but not. We don't have to correct it. We correct it by fixing the nutritional problems.
Yeah, maybe treating the tumor, the cancer. Yeah.
Okay. Which nutritional supplement is ideal in postoperative state to enhance healing or rapid recovery?
Well, I think it's very difficult. There are no data to compare different supplements against each other. We have written in our guideline that those patients who receive radio and/or chemotherapy might benefit from supplements enriched in protein and omega-3 fatty acids with the intention to add more protein and to maybe a little bit antagonize inflammation. But data are pretty frail, and ASCO has published their guideline last year, and they were a little bit more reluctant on this. But I mean, it's one way, and we have not so many tools. So
yes, but if it's possible, I think it's important to privilege enteral nutrition or enteral supplements
versus parenteral.
Parenteral nutrition is less effective and takes more time. So
exactly. Feed the gut.
The principle of ERAS and so on. We have to change a little our mentality as surgeons. Andreas, what do you think about it?
Well, I totally agree. And thank you, first of all, for this nice presentation, Jan. I think it's a setup change, right? And when I speak now from the perspective of a surgical oncologist, I think when the patient comes to us to be seen, to be operated, then most probably we are already in a timing where we are rather late to change something for the patient. And I totally agree with the recommendations. And I have a comment and a question on this part, because I think nutrition is something that already many patients in cancer surgery, like for upper GI, are preoperative chemotherapy, right? So during this time, they should already start with nutrition supplements and also sometimes parenteral nutrition for these patients. Just one question, Jan, because you said if we postpone the surgery for 7 days, 14 days, is this something that you would consider sufficient to do, for example, parenteral nutrition, or is this something which is better than nothing? Or would you recommend maybe even sometimes to have 3-4 weeks of nutritional supplements?
Well, so this is a surgical guideline based on those trials that appear to be reasonable to this surgical guideline group. Basically, these 10 or 14 days go back to Federico Bozzetti from Milano, who did all these trials, and he could decrease complication rates. But then again, these trials are older and they were not based on eras and more modern concepts. So, but still it's in the guideline, and whether it might be better 3 or 4 weeks, we don't know. So this whole prehabilitation, well, I mean, usually if we have a cancer patient, we go to the tumor board and say he's supposed to get surgery. It will not be within 2 weeks, right? Or especially also before you see the patient in the outpatient clinic and so on. So all the time until surgery might be, if it's more effectively used, might be a good time and might be more than 2 weeks. But again, this is a good time also to do trials on this and see what may be improved.
One more short question from for the audience. There are 2 questions, but I think I can shrink it to one question. The question is, do you refer to physiotherapists or design exercises, routines yourself? And the second question is, in terms of exercise, do you advise 30 minutes per session or cumulative per day? Or can you, for example, do 3 walks, 10 minutes each if they tire easily?
Yeah. Again,
so what kind of resource do you need for prehabilitation? That's I think the sense of the 2 questions.
Again, there are not so many trials, and the different groups have done different modifications and looking at lung cancer patients and thoracic surgery or abdominal, but usually endurance training, probably pre-surgery, might be good just to get the benefit. To improve muscle mass, it's probably also important to have resistance exercise. And we usually say 3 or 4 sessions of endurance per week, and like 30 minutes might be good. If you say, I'm just tired early, I want to do it 3 times 10 minutes, probably that's okay. And 2 sessions of resistance exercise. But again, you have to be careful, and there are some groups with exercise experts working with Olympic guys, and they are going on the bicycle ergometer and have like 300, 400 watts, and then they kind of have the cancer patient and they go 20 or 30 watts. So they didn't really have all the experience, and they're working on this. So don't overdo it, but don't tell the patient relax. But so we usually say that the heart rate should go up a little bit, like go to 100 or 110, if that's something to look at.
Andres, your opinion?
Well, sorry, I was muted. Well, I think it's mindset, right? As already Jan said, it's a mindset for the whole group who's treating cancer patients, oncologists, nutritionists, and I think nowadays we are maybe more lucky to have more nutritionists in our teams, also in the bigger surgical departments. I don't know how it is with you, Sergio. But I think it's a mindset change. I think like 20 years ago, the patients were going to the hospital not to move and to be treated and then to go home. And the mindset changed. And I think we are all very motivated to motivate our patients to move and to walk. I think it's a slow but consistent change in the mindset.
Yes, because the actual data literature tells us that the prehabilitation that is in some way followed by physiotherapists is more effective than the self-managed one. But it would, and I think because you have to give clear instructions to patients.
Yes, it should be.
It should be
advised by an expert. And just because with the question whether we or I refer to physiotherapists, we are somewhat limited by what is available and what is being paid. So we have for outpatients, we have like 20 sessions per year which are paid, and we have a trial now going on for patients after curative treatment to offer nutrition plus exercise training, and to see how this works out. But so it's work in progress, and Andreas, like you said, so the mindset is changing slowly, but we still need to repeat it even to ourselves to say, well, damn it, why are we not doing this more and better? But it's I think everybody knows a little bit and gets it more.
I think one important point that Jan just mentioned is that it is in many countries underfunded, right?
Yes.
And,
Yeah.
so the mindset might be here, but the patients don't have the possibility to see a physiotherapist in the next weeks when they need to prehabilitate for surgery. And I think that is the point of the big, maybe first line university centers that are really running trials. And Eras showed this very, very nicely. Sorry. And with more evidence, we can create even, and when it comes to cost effectiveness as well, to create more evidence to get this then finally funded. I think this is crucial, and we are on the way to create evidence.
The last quick question. Very makes sense. I mean, a patient with an upper GI cancer, which presents with poor nutrition, very low protein levels, how to optimize those, because before surgical planning. I mean, head and neck and upper GI are the most difficult patient to treat in that sense. So I think we have to work with the dietitians and
exactly. And I mean, it probably will be the same for you. We have some units with head and neck cancer patients. They say we don't start combined radio chemotherapy without a PEG tube, and others say, well, we have a good nutrition team, we don't need this. So this really diverges, but you should be aware again, have the mindset and watch and go along with the patient. And if they don't take in enough food,
I think there are some clinical problems that are very complex, and you have to face them in a multidisciplinary way. And I think it's a cultural problem, because in my hospital, we have a head and neck surgeons who are very, very, very aware about these problems, so they treat them actively. And we have upper GI surgeons who have the same perplexity about how to manage this kind of patients. So it's a cultural path, the cultural way we have to follow with patience and with determination.
I have one question maybe to Jan and also to you, Sergio, because you were talking about screening, and screening is the first step. And when every patient who's having an upper GI cancer is screened, we already assess the situation and we can act accordingly. How is it in your institute? How is the screening performed? Are you giving a paper sheet while they wait for the consultations, or do you have an app, or is there anything maybe available that somebody from the participants wants to use as well?
Well, for our surgical unit, so I'm not, so this is being done separately. We have different, like the head and neck and surgery also, they are trying to get some screening tool working. What we are doing is we have this digital, when we get our elected patients into the unit, they get a half hour, get an iPad with all the questions, and they fill it out, and it's just being converted and put into the information system. So that's the way we do it. And other hospitals have dietitians go around or have nurses, so it may differ for different settings, and still it's a matter of funding, because best would be not to have any person involved, have it done automatically. The patient enters the house and the screening is done, and you have the time for treatment being paid, but not for screening. And I know several hospitals, they lose all their time just by doing a good screening, and they send out and teach the nurses to do the screening, and all the time is in the end is lost by just concentrating on screening.
We in my hospital, we screen ourselves, the patients, with a masked tool.
Yeah.
And just to screen who is worth to listen to the dietitian and who is not fit to that. We have the dietitian who is coming every day in our ward, in our ward, just to see, to feel the daily input of patients, just to be aware how the nutrition goes on. So I think it is an effective way to lower the need of rescue therapists and so on, and also to answer to the questions that patients always pose. You think, Andreas, you have the same problem. Doctor, what can I eat after the intervention? Do I avoid this? Do I have to avoid that? Or worse, all the self-made diets and so on. So I think to organize your service with a dietary counseling, I think it's quite important. And I agree that we have a great lack of a founding of the screening part. That's for sure. Time is running, so I ask Andreas, please, to show us how is real life about screening and about all that.
Yes, thank you very much, Sergio, for this kind invitation to be here with you. And I'm very honored to speak about our ESSO-ISAC survey on malnutrition assessment and treatment strategies in oncologic surgical patients. Just as a small introduction, I am since last year the chair of the Young Surgeons Group, and we have been very active in the last years about surveys and also nutritional components in the surgery. And I would like to, we don't have any conflicts of interest. I'm reporting on the behalf of our ISAC Research Academy. And the background, Jan was already very clearly and illustrating the background of the problem. As you know, sarcopenia and malnutrition are associated with worse postoperative outcomes. It's just a repetition. I found here a meta-analysis from 2018. There are nearly 7,000 patients regarding sarcopenia, and you see here for major complications that they have a significant higher risk for major complications when they have sarcopenia during the operation. And also the perioperative nutritional supplementation decreases postoperative complications. This was shown in another meta-analysis from Sang in 2019 in patients undergoing GI cancer surgery. So from this to state about our Young Surgeons Group within ESSO, we have been conducting several collaborative studies, and we are ongoing with new projects. And one of them was also our nutritional survey that I'm happy to present to you. And we had the Corsica study about rectal cancers and more important, the nutritional assessment in surgical oncology. This was a large online survey. We nearly had 400 participants from all over the world. And I just copied here the conclusions of our paper. And that fits to what we were already discussing, that nutritional assessment is largely neglected. And we can take this snapshot study and also our study that we conducted this year to carry things further. As we have already seen, presented by Jan, the ESPEN practical guidelines were updated this year for clinical nutrition in surgery. And it's the evidence is growing and growing. And I would also like to make the point that we know a lot and we are willing to do, but we have a lot of course, aspects that are making us not to be maybe as consequent that we screen 100% of the patients. And I think one important aspect, we already spoke about this, is the underfunding, is the lack of resources in the hospital or in the outpatient clinics. I remember very well my time when I worked at Charité. Of resources were important. Here about our study, and here we have our inclusion criteria. So we made a snapshot study online about patients who are treated for oncologic reasons. So we designed a questionnaire, in total 41 questions about several aspects. We wanted to be a little bit different than our snapshot analysis of last year. So we also asked specifically some aspects which are in the ASPEN guidelines about, for example, preoperative food intake or liquid intake, what is the common practice. And we assessed the screening component, who's responsible for the screening and the treatment, how often is nutritional aspects or malnutrition aspects reported in discharge letters, for example. And we did the analysis, and I'm happy to show you now the results of this study. So the observation time was a bit more than 8 weeks. We wanted also to have the analysis performed for this webinar. So in total, we had 156 participants, and more than half of them were from Europe, and we had nearly 70 from other parts of the world. We didn't have any responses from the US or from Canada, and the majority of the participants were below or 40 years old. And we also asked the participants, how many patients do you see per month which are under your consultations or operation room? And the average number per month was 22 patients for the participants. When we see here about the screening, we were also open for non-physicians like nurses, dietitians, physiotherapists, other professional healthcare workers. But you see that the vast majority were doctors. And when it comes to the specialty split, the majority was general surgeons. We had upper GI surgeons, then colorectal, peritoneum. We also had gynecology, urology, and then sarcoma, breast, HPV. There were then just less than 5 participants. And that is always, we also recognized it in our last survey, it's always then difficult to get very concrete answers because the participants are a broad variety of disciplines, and the breast surgeons might face less nutritional or malnutrition patients if they are not metastatic than maybe colorectal upper GI surgeons. So therefore, it is a little bit difficult to have an overall assessment then of our results. But coming now to our responses, the first you have already seen in the chart graphic. The majority of the participants, 80%, were coming from university or from teaching hospitals. So I think that is maybe also a little bit of a bias to the results. What is common practice? What is happening maybe with less resources in smaller rural hospitals? And what is, I think, interesting, our oncology patients routinely screened for risk of malnutrition at your institution. And you see here that 56% were answering no. So only 38% of all the patients are screened. And when you followed the presentation of Jan, we know that 30%, or in some specialties for sure, more of the patients have malnutrition. So this is something that we, of course, want to assess now, and it gives room to improve. When it comes to the protocol and screening, you have been already introduced to all these protocols and screening questionnaires. So you see that not a small part of the participants have their own protocols, or their institute own protocols for malnutrition, which is, I think, great. And the majority follows ERA's guidelines and protocols. And then we have ASPEN and ESMO and ASCO and others. And as you see here, the majority are not performing screening, as I already showed you in the other table. And then the MUST questionnaire is one of the most common, followed by the NRS 2002. This for sure is also related to the countries that were answering. So I think in the top 3 countries, there was Pakistan and also the UK, so the English-speaking countries, and I think they are rather often using the MUST. When it comes to the responsibility who is assessing and who is monitoring the nutritional status of surgical oncology patients. Of course, the responsibility is with us, with the surgeons. But as you see there, and this is what I mentioned before, there are quite a lot settings that provide a dietitian in their team. And I think that is absolutely important to have them in the boat from the first moment on. And here at the foundation in Lisbon, we are also very happy and lucky to have our new dietitian nutritionist with us, Dr. Marta Cristo. And so that is actually the setting. Oncologists are then more after the discharge, when the patients go on chemotherapy, who are monitoring the nutritional status. Then we have common practice questions here. So this is what I mentioned before. We had some questions that we were just asking, for example, if ASPEN guidelines are present in every participant or not. So how long would you preoperatively allow your patient to drink fluids? And you see that the majority, so more than or nearly 60%, are allowing 2 or even 6 hours to drink the patients. But that also means, on the other hand, that 40% of the patients are not starving, but are not drinking fluids more than 6 hours before the surgery. And I think we have evidence for that this does not have to be anymore like this. When it comes to food intake, you also see that 6 hours, 8 hours, even 12 hours or midnight, depending. So we have also a rather maybe strict traditional way, but nevertheless, already 20% are with 6 hours. I think this is something that we already spoke about, mindset and so on. What proportion of oncology patients under your care are monitored for nutritional status preoperatively? This we already discussed. This is low. This is far less than 50%. And how often would you postpone surgery? And this we come now to the ASPEN guidelines that Jan showed us. In case of a malnutrition, to treat the malnutrition, and only 56% would postpone that. On the one hand, I think that might be a fair answer of the surgeons, because we also know that sometimes there are situations where we might not be able to postpone surgery, or we have, of course, administrative maybe reasons to push for surgery, or maybe also the reason that maybe a prolongation of the operation would not be oncological smart or not reasonable in the end. The majority, of course, the food intake is monitored during the hospitalization time. And we were also asking about immunonutrition. So for upper GI cancer patients, do you consider immunonutrition? So a third of them were considering, which is, I think, a quite good result. And then we were asking, and dare I say, it becomes difficult because we have a lot of different specialties. When would you start enteral nutrition postoperatively? We are performing the subgroup analysis, but when it comes then to upper GI cancer specialists, we have like 20-25 in our survey. We have to do the subgroup analysis. But in general, the participants were in the first day or on the same postoperative day. But as I said, it is a difference if that is a breast cancer patient or if that is maybe a peritoneal surface malignancy patient. So then just some numbers, what proportion are monitored for nutritional status, and there you can also see after the discharge the number goes down. So after the discharge, the responsibility is either switched or maybe even somehow not as considered anymore as preoperatively. This is some interesting data about the risk of malnutrition in general. Jan showed in general that oncologic patients have a risk of around 30% to be malnutrition. In our survey, the risk was higher. In the centers that were screening, we had a risk of 53%. And in the centers that were not screening, they were estimating more or less the same number of 55% of malnutrition. And what is interesting, and that was also mentioned, that is maybe at the moment rather a research topic about the sarcopenia. So who's evaluating muscle mass by different kind of methods. And you see that the vast minority is only assessing this in the best case 20%, which I think is also even a bit optimistic in our survey when we compare it maybe to the real world scenario. So this is for sure one topic which might be important to improve in the future. Then we have seen the dietitian. 50% of the patients are seen by a dietitian when they are in the team, and then we have postoperative feeding in the postoperative period, and what proportion of patients are fed by enteral route. So this is difficult to interpret, but I was putting here the data. And this is also something where I think we have to think and to improve when we need to take things, I think, serious, and we also have to report about our malnutrition screening. And I think in the doctor documentation, as well as in the discharge letters, as nutritionist status and nutrition treatment must be mentioned. So at the present stage, 38% were mentioning this information, which I think needs to improve. You will agree on this, I guess. So coming now to the conclusions, and in total we had 156 participants with an average of 22 patients treated per month. Our screening or the screening for malnutrition in oncology patients is not the norm. So we see there's huge work to be done to implement screening, and then also, of course, treatment. We see that when it was performed, the most common used screening questionnaire was the Malnutrition Universal Screening Tool, MUST, and 52% of the patients are at risk of malnutrition. And when it was not performed, the estimation was around the same, with 55%. Nearly 50% of the patients were seen by dietitians, which I think is quite a good number, but of course, in the ideal setting should be improved as well. Saying this, I would like to thank, of course, all members of our ISAC Research Academy. We are a very diverse and active group, and of course also to all ISAC national representatives. And with this, I would like to thank you for your attention. You'll see here my email and Twitter contact in case you want to contact me in the next days or weeks. Thank you very much.
Thank you, Andreas. There is quite an interesting question, if I can, from the floor. How did resource management in view of the pandemic crisis has influenced your practice in terms of deferring surgery to improve nutrition status? In other words, how the pandemic has biased your survey, or maybe have influenced some results. What's your impression? I know that you had no data on that, but this is a very good point.
I think first, if I answer it from my institute, and then second, I will answer it maybe for the cohort of the survey. From our institute, we were rather lucky because we are a private cancer institute, so we don't have an emergency room. We don't have COVID patients in our institute. So from that reason, I would not have to say that we had a lot of delay of referrals, or we had a delay of operations. But when it comes to my colleagues and to the participants and to our group, I'm very much aware of that. Of course, with COVID, we have a quite huge delay of patients. First of all, on the diagnosis side of endoscopies, and which were paused during several months. And many patients showed up with quite advanced cancer stages, were operated with colon cancers in ileus or perforation, which was much higher than before the COVID. And I think that in such cases, of course, nutritional needs or maybe prehabilitation might be less relevant than in such cases during this pandemic. From our personal view, from our institute, I think from our nutrition assessment, nothing changed. But I think when it also comes to resources of the lack of nurses, because nurses were getting ill, and I think that most probably nutritional aspects were more put to the background.
I think that your survey has snapshotted in some way the attitudes, rather the actual situation. I have to admit that the pandemic has not helped us that much in this kind of a situation. But Jan, what's your opinion on that?
So, you mean you're asking whether the pandemic has decreased the willingness to answer, or because
what's your impression? You're not a surgeon, but how the nutritional issue has been in some way underestimated because of the pandemic issues?
Yeah, I think so. That maybe nutrition goes a little bit back into the background. However, with our patients, well, then it's not surgical, but we are seeing the same number of patients in our outpatient and inpatient, and so they also we have the same number of dietitians, which is low, but they still see the patients with problems.
I think that the pandemic has made things more complicated, but
sure,
we haven't changed the attitude or the importance of the issue, I think. And there is another question, but I think we can answer very easily, because one participant on the floor asked us if we have found any relation between low serum albumin level or altered AG ratio and anastomotic leakage. I think that all the indicators of malnutrition are linked with a high percentage of complications, postoperative complication. I mean, the surgical site infections or anastomotic leakage, because if your nutrition status is impaired, also healing is impaired. I don't know if you have something to add.
No, I would say some complication, but no, Andreas said. Oh, please.
No, I certainly agree on that, but maybe just to highlight again, the serum albumin is just one marker which shows the whole, or indicates maybe the malnutrition whole picture of the patient. And
I think it's very important what Jan underlined concerning the meaning of low albumin. That is more an indicator of chronic inflammation and of malnutrition as a consequence. So this is the answer. If you have a chronic inflammation and malnutrition, your healing capacity are absolutely lowered, poor.
Yeah.
Okay, if there are no more questions, I ask Andreas if we have time. Maria, do you have how many time do you have?
I think we still have 20 minutes.
Okay, so we can propose some case studies, Andreas.
yeah, we were conducting together two cases just for a poll to make it also more interactive. And let me share here the screen. Yeah. So just to introduce, to make it a bit interactive, you can vote via the poll function. Maria will open this after I finish here with this slide, and we would like to discuss your opinion and also the answers then at after case. So this is case one. It's a simplified case, of course. It's a 43-year-old gentleman who presents with 3 months history status in our practice. He has progressive dysphagia and a weight loss of 10 kilograms. He's currently only able to swallow liquids with difficulty, and the upper GI endoscopy shows a structuring, growth and tumor at 25 centimeters from the incisors. With an endoscopic biopsy, it was diagnosed as a moderately differentiated squamous cell carcinoma. So this patient with esophageal cancer. Our questions are, how would you assess the patient's nutritional status in your routine practice? And would you assess frailty in this case? And what would be your strategy for nutritional supplementation of this patient in your routine practice? So we go to the question number 1, and Maria, if you could open the poll. So please take your time and choose what your common practice is. If you don't know the acronyms, after this webinar, you are aware of them and you know them. Maria, how many votes do we have so far?
15, so 36% voted.
We have more than 40 participants. Maybe
I'll wait a bit. We're getting a few more.
Don't be shy.
you can only choose one option. So Maria, do we have 30 now already?
Oh, we have 50% now, so I think maybe I can end the poll.
Perfect, yeah.
Okay.
And here are the results.
Okay, so the majority is also using the must. One person would not assess the patient's nutritional status.
Even though there was an important weight loss,
Mm-hmm.
and there was not the time lapse of the weight losing. Were no data about his BMI, but anyhow, okay.
Sorry, I think I now. Do you see the question 2 now in the or do I share? Okay, so then we start with the question 2. Would you assess frailty in this case? We haven't spoken about frailty in detail today. But frailty is an important factor, of course, when it comes to complications, to length of hospital stay, to also the resources that patients need to recover.
Yes. The autonomy or independence of patients, the functional issues, and so on.
I think if we have 50%, we can show the results.
How to assess frailty? Jan.
Yeah, that's right. Well, I mean, I know some tools for assessing sarcopenia, but frailty again is something different. And I think as a surgeon, you will always have an impression of the frailty of a patient. I mean, you see the patient before surgery and you have an idea, but to do an objective frailty test, like having somebody maybe have a walking speed or have a stand up and sit down procedure, and there are several different tools. I don't know what is your favorite. In fact, we don't really get to do them, even though we know them, but I think for surgery it might be even much more important.
Yes, because assessing frailty helps you to understand how performant will be the patient in terms of recovery.
Yeah.
The first day's recovery. If you are frail and you have a great fatigue, it's very hard to stand up from the bed or just to be compliant to the fast track principles. So I think it's important, and it's linked to sarcopenia in some way, because sarcopenia is or cachexia assesses just the loss of resources, and frailty assesses also the functional autonomy or the functional reserves. Andreas,
So the effect on daily life, yeah, exactly.
yeah, effects.
So, but would you have a favorite test to do, or say? And the frail patients would need much more physiotherapy,
yeah,
devotion after surgery for recovery.
Yes, absolutely. So, but I wonder how many times do we ask our patients if they are able to rise from the armchair or just are autonomous to dress themselves. Yes, we can ask it, of course, but do we have this kind of new in our mind as a routine questionnaire? I don't know. I'm not that sure. Sometimes we discover that patients are frail once they are in our wards. Andreas, do you agree or not?
I totally agree. I mean, we as a surgeon, in our consultations, we have a sense of the patient, right? And we might already know this patient will take long to recover, or this is a big surgery for an old and frail patient. But I agree, because in the end, what is the consequence that we are taking out of that? Sometimes we discuss the patient with the anesthetist preoperatively, and then we come to a conclusion that maybe that surgery is too big for the patient. So we say, okay, this is too much. But in my practice and from where I have worked before, on the ward, there is actually not a big consequence. Of course, you can maybe increase the physiotherapy units for the patient. That is something that we can do. But I think we are not yet there, from my understanding, to really individualize somehow the treatment to the patient's need.
Yes, we have to keep in mind that we surgeons, we stress a lot our patient more that I think that more than Jan does with chemotherapy. Chemotherapy is hard to bear, but I think surgery, when it's a long surgery or a heavy surgery, stresses a lot.
Yeah, you're accumulating it in a very brief time.
Yeah,
right?
okay. That's right. That's right. So, Andres, please go.
There's just a question to frailty in the chat that I just put here from Mohammed Rahman. Could frailty be an enough indicator for sarcopenia?
Jan, what do you think? Well, yeah, I think all these questions need to aim at some response. So if I'm looking at sarcopenia, if I'm looking at frailty is even more daily life associated, you want to help the patient. So either you decide the patient is too frail, he's too sarcopenic to tolerate this planned surgery, or I'm saying, well, he's so frail, we need to enter a lot of physiotherapy and other care after surgery. So it needs to have an effect if I'm doing this assessment, right?
I think that the right answer is that frailty doesn't necessarily mean sarcopenic. And sarcopenic doesn't necessarily mean frail. Mm. Frailty is a functional indicator.
Yeah.
And sarcopenia is a resource indicator, if I can.
So you need, if you're working on this, you would say you need to screen for both. You would need to screen for sarcopenia plus frailty.
That's right. So this is interesting. I hope that the majority will answer to this.
We have question 3 now in this patient. Just to remember, esophageal cancer patient with weight loss and inability to have more than liquids. What would be your strategy for nutritious supplementation of this patient in your routine practice? Would you do nothing? Would you do consultation of a dietitian? Would you perform oral supplements? Would you do oral supplements and a consultation? Would you add enteral supplements or parenteral nutrition in this patient? Please answer now.
Okay, here are the results.
Okay,
Quite a good amount of correct answers. 50% were right. We already commented the role of parenteral supplements in these cases. Jan, any comment about this?
Well, yeah, and to be fair, probably there may be patients who will require parenteral, and there will be patients who might benefit from an vaginal tube, and so, but most would be B and C, I agree. But again, of course, there may be patients who will require some of the other options.
Andreas, any comment?
no, I think we were also rather simplistic with the case description, so we cannot really see. But I agree, it's good that nearly everybody would do something in this patient, of course, with orals, and if that is not working, then sometimes this patient need parenteral nutrition.
Okay,
great. So then we come to our second case and last case. This is a case. 65-year-old gentleman presented with an icterus and a pancreatic head tumor in your consultation. The tumor shows vascular involvement, so more than 180 degrees contact to the venous confluent and no arterial involvement. Is a hyperbilirubinemia with 14 grams per deciliter and an increased tumor marker CA99. He has no signs for distal metastasis. His weight loss was 16 kilograms during the last more than 3 months. And he has a BMI of 31.7, so he's an obese patient. And the patient was scheduled for a biopsy and a stent, and most probably the neoadjuvant chemotherapy or palliative chemotherapy. However, the questions are now the same. So how would you assess the patient nutritional status? We can already go to this and open the poll. You already know what would you choose in this patient? Would you choose differently than to the other patient, or is routine screening for everyone?
Yeah, the confounding factor is the BMI in this case, I think.
But it's the way the patients are going nowadays, right?
Yeah. More and more we are seeing this kind of patients.
Participants getting a bit more tired, I guess, now at the end of our webinar. Please vote.
Yeah.
Okay.
Good. So
okay. They tackled the trick. They correctly tackled the trick. I was fearing that the answer was I not do screening because BMI is high. Just go on.
Mm-hmm. The second question about frailty in this case.
65 years old, good BMI, and so on.
Is maybe a rather fit patient from the description.
Yes. Okay. Any comment about that? because I think the problem of this guy was the loss of lean mass because of the quick loss of weight. So are you enthusiastic about the frailty assessment in this case, or not?
How would you do the assessment? What would be? I mean, it depends on how complex and time consuming.
Yeah.
I mean, for screening for malnutrition, I would say the physician does not need to do it. The surgeon doesn't need to do it. The oncologist, somebody needs to do it. You just get the result. For frailty, it's maybe a little bit more complex. If it's just having somebody stand up and sit down 3 times and it's for your impression of the frailty. If it's more complex and somebody needs to do it, or you want to do it yourself. So that was my question. What would be your favorite? Is it more you just look at the patient, you have an impression of the frailty, or would you do an official kind of test with several, I don't know, actions or questions?
Well, we are using the 6-minute walk.
Okay, so what you have 6 minutes, somebody needs to take the 6-minute time.
Yeah. Yeah, that's right.
Yeah, I mean, so it's just connected to some effort.
So it's not that easy to I think that the frailty assessment is a less simple thing thing we can assess. Andres?
Well, in our practice, I have not assessed frailty, to be honest, and in a patient just of
You're honest.
Subjective impression, which is
you're honest. That's right.
Is not a valid test, right?
But we have to get people aware about the importance of this aspect. That's
absolutely.
That's the aim of this kind of webinars.
So then the last question: what would be your strategy for nutritious supplementation in this patient? Do you think he needs nutrition? Well, he still has a BMI of 31. I think in this patient, and I don't know your opinion, Sergio and Jan, a sarcopenia measurement with a CT scan, which might be the easiest way to do, because they all have CT scans, and it is data which needs to be assessed, and is maybe important. How do you think about that?
Yes, I think the CT scan assessment is the right thing to do. This case focus on one of the problems we are facing more and more, that is sarcopenic obesity. I mean, people who seems to be not that in bad conditions, but due to the huge loss of lean mass, is more malnourished than it appears, and they are. Yeah, please.
Yeah, I think so. Probably these 16 kilograms will be more than 5% of the weight.
Yeah.
So this person is malnourished and he is losing weight. So this might go on, and he will have lost tissue and muscle mass. So I think some nutrition, and again, some nutrition would mean protein, counseling on protein, and at least probably we always say these patients should not lose any more weight. They should be stabilized.
It should be stabilized. That's important, because we have to reconstitute. But do we have enough time to reconstitute lean mass
before surgery or whatever?
Yeah.
If you're planning adjuvant chemotherapy, I mean, you just do it simultaneously.
There's a question about the advice of a jejunostomy or enteral feeding tube in such a case. I think it's a little invasive, and it is in the chat, Andres.
From my experience, these jejunostomies, they also have some complications, right? They're not zero complications procedures, and whenever you had to reoperate a patient after 2 or 3 days because he had an ileus or torsion or whatsoever, from my understanding and from my practice, we don't need these feeding tubes, or we don't use them. Let's say like this. Maybe in some patients, like after Whipple's procedures, when they have a delayed gastric emptying, which is very long lasting, like 3, 4, 5 weeks, sometimes we have these patients, right? Sometimes we put nasojejuno tubes to feed them. I think per principal placement of jejunal feeding tubes operatively, intraoperatively for gastrectomy and for Whipple procedure has, from my opinion, no place. In the esophagus, it is maybe something different. Then we have to assess, and in some cases it might be useful, but for gastrectomy and Whipple, I would not do so. I don't know about you, Sergio.
No, I totally agree with you. I think that the too invasive solutions are not real solutions in these cases. Jan, one quick question, I think is the last one. Do you think that in such a case, dietary counseling and oral supplements can be enough as a...
Yeah, I don't know whether...
And generally speaking, I know that it's...
I know. It always depends on the timing and what is the treatment procedure. And I would always like so they did this effort trial in Switzerland where they said, well, intensified nutritional counseling is beneficial, but so they escalated after always 4 or 5 days of energy intake was not adequate. So start, and if this doesn't work, we would usually have a central venous access, and we would add some parenteral nutrition just as a combination, and then try to get the oral route working.
But if you don't have a central access, maybe an attempt with oral supplements can be makes sense.
Sure. Yeah, sure, definitely. So I think counseling and oral nutritional supplement should be the first option, and then just see how far you get.
Okay.